Hello, this is Jonathan Munoz, and today I'm going to give you advice on how to perform well during your observerships or rotations in the United States. In preparation, of course, for your application for the process for a possible courtesy interview at the program that you're doing the rotation. So, let's go directly to it. There are going to be instances where we will send you to do an admission or we will send you to do a progress note. So usually a hospitalist, pediatric hospitalist or family practice or internal medicine hospitalist manages a list of 10, 14, 15 patients. Of course, they are not going to give you the 15 patients for you to manage or to go around and do your own thing. No, they're going to give you 2 or 3 patients to see how you do, how you manage yourself. So I'm going to tell you, hey, okay, I'm going to give you these 3 patients. You go do your progress note or do an admission note on them and then report to me. So you have to know that the way that you report to me is you prepare your whole progress note or your whole HMP and you send me that. You email me that or you print it out and give it to me so I can evaluate it. If you email it to me and it's a good progress note, I can use parts of that progress note, those paragraphs that you wrote, into my progress note and saves me a lot of trouble. So I will be like, oh, okay, this student is someone I can rely on to get this information. She really went to talk to this patient and got me meaningful information. So what is that meaningful information that you have to know? Okay, so for the admission, if I send you to do an admission, it means that I'm going to send you to the emergency department to introduce yourself to a patient to get the whole history and physical exam and your assessment and plan. That is the whole admission. So I would say, hey, they called me to admit this patient in the emergency department. She is on bed 15 in the emergency department side A or B. So go there and do the HMP. I will come to see you in an hour. Usually we give students 1 hour first because it takes a while for you to develop the skills to do it faster. So you go do your admission. What is important for you to know when you do an admission here in the United States? We like the information that you provide in the OPQRST format. Why? Because that is the way that the computer system is built and that we have to enter information based on the OPQRST to make up points that that create a code based on what we build our nodes. So the more points we introduce that meet the criteria for a high node, for a high value node, the more we get to build the insurance of that patient with proof of work, the node. So basically, every aspect of the OPQRST gives us 1 point. The more points we get to the highest level 3 node. So remember, the OPQRST is a format that we use here. In most countries, they don't use the OPQRST. They just go to try to create a story, and the creation of a story not always have the OPQRST points that we need. So I would suggest to start with something like 87-year-old male patient with past medical history of diabetes, hypertension, comes in with a chief complaint of chest pain, of 3 days of time of onset, is getting worse for progression, has a quality of pressure sensation, with radiation to the left arm, and severity of 6 out of 10. With that, we already got the points that we needed. And then the other thing that it helps, if you're gonna do something for us, and this is the admission note, what helps us the most is that you give us a good medication list, that you obtain the medication list from the patients or their families, that you say, by the way, do you have your medications list at hand. And if they do, and you write it down for you, and then you tell me this patient has atrial fibrillation, is on Eliquis 5 milligrams twice a day. She's also on amiodarone and digoxin and metoprolol because she has terrible atrial fibrillation, and she's coming here for cellulitis. Then I know that while treating the cellulitis, I can't forget to put this patient on Eliquis, to put this patient on amiodarone and metoprolol, because the treatment of one doesn't mean that I'm going to forget the other one. And if a patient with atrial fibrillation is not on proper anticoagulation, then I run the risk of getting a PE or DVT because I focus only on the treatment of cellulitis. So early on the game, early on the first day, ideally I should know which medications this patient is taking, so I can make sure I put them back in if it's appropriate. For example, a patient that is coming for a UTI and sepsis, and she was taking 20 milligrams of prednisone a day for her rheumatoid arthritis. If I don't know that piece of information, then I probably won't treat this patient the right way. But if you give me that, then I will say, oh, then this lady needs stress steroids today. I will be like, good job. And I will probably remember that for your letter of recommendation. So some medications are very important. Remember that. And one big thing that you can provide us and help us with is with the medication list. The next one, code status. Like, I will say this is one of the most important things that a student can give me. It will really make you shine. And if I see that you report in your email or in your oral presentation that you discuss code status, the best you could, because at your stage you're not going to be perfect for this, but the best you could, and you say, by the way, I discussed with this patient the code status, and she has a living will, and she is DNR, DNI, then I will be impressed, because, guys, medical records in hospitals in the United States require for a patient to have code status on admission. Now, usually, because we don't have that much time, we default to full code, which means resuscitation and intubation in case it's needed. But in many instances, patients that want to be DNR, that have living will with DNR, end up being full code because the admitting doctor didn't ask in time on day one what they really wanted. And that can cause trouble, because if this patient is full code and if this patient is DNR and he gets intubated, the family will be pissed. The family will be like, my dad is DNR, why did you intubate him? He has a living will. Did you ask? You didn't ask me. Did you ask my dad? My dad is demented. How come did you ask my dad? How come did you decide for a demented patient that he wants to be full code and you didn't ask the power of attorney, who is me? I don't remember your call. So if you as a student took time to investigate all this and weren't shy and were brave enough to call, make a phone call and say, I'm the student working with Dr. Munoz, and today we're admitting your father to the hospital, I would like to ask you these questions. One of them is if you have a living will. You don't have to go in detail. You can leave that for your attending, but you have to get the basics, and getting the code status is one of those basics. Okay, let's go to the next one. The rest of the history is important, including smoking, family history, the physical exam, of course, because those parts also add points to my goal, which is to be up for the highest level based on proof of work, which is documentation. So that is for the HMP. Then it comes the part that even if I just listen to you, and even if what you recommend may not be right, because you at this stage don't know the whole treatment that we use for our patients, but you're thinking in the assessment and plan, is what I'm evaluating. The way that we evaluate patients is hard work and knowledge. We evaluate the hard work by you doing the first part of the admission part or getting all this information, and we evaluate your knowledge by discussing the assessment and plan. And the best or the better you work on your assessment and plan, you tell me this patient problem number one is chest pain. We need to rule out ACS. And I say this because the quality of his pain, the troponin elevation, and the changes on the EKG suggest that this is very likely to be unstable angina and less likely to be an NSTEMI. I suggest that the treatment should be heparin, initiation of metoprolol, initiation of aspirin, Lipitor, and pain management. I want to get an echocardiogram, and if the results are concerning, we should even consider including a cardiology consultation for possible ischemic workup, which means an angiogram or stress test. Because some facilities here, for the stress test that we sometimes get to order, the nuclear stress test or the treadmill stress test, it needs the supervision of a cardiologist. Some states don't need that, and the hospitalist can order that and supervise that, but some states require a cardiologist to do it. For example, a heart center. Okay, and so don't forget the assessment and plan is very important. We evaluate you with that, and you basically have to just go through any problem that you found while doing your HMP, like electrolyte imbalances, deformities in the body, anything, you list it there. Chronic conditions, you list it there. Okay, so list everything that is abnormal with an etiology and possible explanation, pretend a treatment plan, we talk about that, and make a follow-up list for the next day. So when you create your assessment and plan, you say, oh, I want to get an echocardiogram, I want to get the troponin trending times 3. It's not just for you to say that, but the next day, that patient will be assigned to you. That will be one of the patients that say, oh, okay, today you're going to follow up on that patient that you admitted yesterday. So what you're going to do is you're going to make a follow-up list where you go the next day in the morning, you go to the patient room and say, okay, let me see at the chart and see what's going on with the troponins. The troponins were negative or was one that turned positive? What is a repeat EKG? Did something happen overnight? So that you follow-up list on that patient. Why? Because with that follow-up list, you're going to create your progress note for the next day. So the next day, the progress note. So if you want to impress and you want to be on the good side of an attending, by the time the attending arrives to the hospital, you should already be in there. You should already know what's going on with your patients. So arrive earlier than the attending, follow up on your pending things from the day prior. For example, what I said, follow up on your results, on the patient's reaction to medications. And do your report on a SOAP note format. Your progress note is going to be on a SOAP note format. SOAP for just S for subjective, O for objective, A for assessment and plan. Objective has the physical exam. So for the subjective part, you're going to say what happened the day prior that you left. When you left, what was pending? What happened? Did the troponins trend positive? Did the patient experience recurrence of chest pain? Did the patient had his echocardiogram? And what's the result? So you can say something like, overnight the patient completed his troponin trends and the results were below, the results were negative, and a repeat EKG at midnight showed sinus rhythm. The echocardiogram was completed and showed an ejection fraction of 60% without wall abnormalities, and overall the patient is tolerating diet, no telemetry abnormalities, and denies any chest pain or chest pressure. So then you go to the objective part, and then you do your physical exam. Now the physical exam is more focused, and after that, the assessment and plan. When you, on the second day, with all this information, your problem number one from the first day cannot be the same on the second day. So the second day, you should have a better idea of what is going on. If you were indecised in between NSTEMI and unstable angina, on the second day, you should have a better idea. You should say, this is NSTEMI. Therefore, we're going to add X or Y treatment, and we're going to consult cardiology to proceed with an invasive workup. Let's see. So update the status of the other problems. So many patients that you will see, you will admit for the problem number one, which is the problem that is going to kill them, but then you will also have to list chronic problems. Like if they have diabetes, you have to mention problem number two, diabetes. Is it controlled? Is it stable? Is it out of control with hyperglycemia? So if it's out of control, what's the plan for that? Are you going to suggest that this patient starts on insulin? Are you going to double on the sliding scale? What are you going to do about this? And for always keep an eye on the need for physical therapy. For example, very important, because we forget about involving physical therapy, and we call them the last day, the day that we want to discharge, the day that the patient is stable to discharge. We call physical therapy because we realize, oh, I don't know if this patient can walk, therefore I don't know if this patient can go home. So you, the astute student, are going to say, Dr. Munoz, the patient is improved, can we call physical therapy in anticipation for possible discharge in the next 2 days? So physical therapy will come, and will evaluate how well can they stand or walk, and will tell you, Dr. Munoz, I don't think that this patient will be able to go home. Maybe you should consider sending him to a skilled nursing facility for 1 or 2 weeks prior to transitioning to home. So that is important. I'm saving 1 day of hospitalization by getting physical therapy in time. Why? Because if physical therapy says he will likely need to go to a skilled nursing facility, I tell the case manager, and she does all what she can to get this patient to these facilities. Therefore, I save 1 day, my list is smaller, and I can work on other patients. And also, as a astute medical student, you're going to remind us, Dr. Munoz, our patient is 89 years old. She has severe sepsis. She's currently on 3 vasopressors, and she's not responding very well. Do you think it's time for a hospice consultation? Do you think it's time for us to discuss again if we should continue doing all this, or is it time to stop our efforts and allow this patient to rest? And you wouldn't imagine how many times such conversation takes you to a whole different level with the families, because the family said, yes, Dr. Munoz, I think we want our mother to be comfortable now, and for you to stop all the treatments and allow her to pass. But usually that conversation is called the end of life conversation. So someone has to think about it. And I will tell you, I'm very good at thinking about starting that kind of conversation when a patient is not responding well, and there are factors that tells you, this is something appropriate. But I have partners, or I have colleagues that work with me, and they don't even think about it. And they keep treating and treating and treating, and you could save so much suffering. You could save so much effort, so many resources by thinking about this at an early stage of the treatment. So that is my advice for your rotations, for your observerships. If you're happy or you're lucky enough to get an in-person rotation, this is something that you should do to impress, to get on the good side of your attending, hopefully to get a very personal, a very detailed letter of recommendation. And if you need some instructions on how to do a letter of recommendation, please look at the previous video I posted this week to get some pointers.